Well, listening to all of you people, and at the end of the day, and since we've started by saying that chronic pain is a chronic disease, so why isn't it treated like all other chronic disease? I mean, and why shouldn't we treat it like all other chronic disease, and why it is not treated as such? What's your answer to that?
Okay. I think there's several parts to it. One is it has things in common with mental health. Pain is a subjective phenomenon. Nociception is a physiologic phenomenon.
So that's the elephant in the room.
Phenomenon. Yeah, and so the issue being that if something is only subjective, what are the measures that we use? Where do we get Pat's quality indicators for tracking improvement? Part of the problem is many of the patients who suffer from chronic pain, by the time they are identified as having chronic pain, so if you go through your 2-year wait list to get into my clinic, then you definitely have chronic pain by the time you get there, but frequently you don't have a job. Often your dog has left you because you're intolerable to deal with, and you are not a vibrant, viable member of society at that point, and nobody cares where you're going to vote because you can't get out to vote. So I think that's another issue.
I just wanted to add to that the importance of measurement. And I have to say I was really pleased to hear Eve talking about measurement from the basic science perspective as well. And I think that is a major issue across the lifespan in terms of really being able to measure pain intensity. We have problems with nonverbal populations, with extremely ill populations in intensive care units. And for those who can self-report, people question the validity of that. So I think measurement is a big issue. I think we're making big strides in looking at new ways to measure pain, but I think that's one of the big issues around what you've just asked.
Carly's still thinking. It's a big question. I think in addition to the measurement piece, I mean, I agree. I think the subjectivity and the difficulty seeing it is a piece, but I think there's a need for a shift in attitude and beliefs about it. I think we don't treat it the same way as other chronic disease from the start. And whether that's how we talk about it. I mean, people have talked about education already. Like, I think how we talk about it within healthcare providers, it isn't given that same kind of weight that I think other types of chronic disease.
But then we started the day with Linda Porter from the NIH, who was telling us that the IOM report's title was Relieving Pain in America. So shouldn't the title of this report should be Living with Pain in Canada?
I like how mic drop. It's like just leaving like that. So thank you for that as well. And what I really love about having this panel at the end is it really brings us down to the nuts and bolts of it, as you say, in this real sense of what does it mean to be living with pain and what do we actually do about that. And you guys have given us some really good starting points, I think. Just to signal what we're doing for the rest of the afternoon, we're going to have one more conversation to respond to this panel's perspectives, one more quick table conversation. Then we're going to have a break. And then when we come back, I'm going to be posing to you the challenge. What should the CAHS focus on? So the last hour will be on that topic. So just to prime us for that, I'm going to ask you to do one more quick table conversation with the panel here to respond to your questions. And this time, I think two focuses. One is about how do you incorporate patient voices and perspectives? Like, what are you hearing and what else do you have as an idea? You've laid out really well, I think, a lot of the options. But just what other insights is this leaving you with about how to work toward a national strategy? So beyond the patient voice, sort of Louise's point, to the points that we landed with last time, like what are the things you're hearing as the important pathways? So if we can just do that for 5 minutes, then we will have a break and then we'll come back and pull it all together. Okay, so 5 minutes at your tables. You may begin.
All right, so our table again wants to address the first point on the slide with an innovative idea for a national way to bring patient voices and perspectives to the pain question, which is to hold a pain pub night. And I will share with you that last night I hosted 160 people from the general public in Vancouver to talk about ethics and neuroscience discoveries at UBC and in some of our high schools. We had 4 brilliant presenters. I had a waiting list. We held it at Steamworks just down the street. I had people who I couldn't let in because we filled up the house. And we think that if we held a similar pub night or pub week, let's say, across Canada, videotaped it so patients' voices could be heard, bring experts speaking in a very engaging way and listening to the questions around the audience, videotape it, maybe FRSQ and CIHR, some of our other funders can help take that video and make it into a really professionally developed product, and then we could present it to our government officials using the expertise of policy entrepreneurs. That's a new expression I had never heard. We could have some pretty powerful voices brought to the table in what would be a very coordinated and powerful strategy.
Lovely, thank you. Did you have 2 thoughts? You're still clutching the mic, so.
No, I'm looking for the next.
Okay, you're passing it on. Awesome, thanks.
Can I just comment on that quickly?
Yeah.
I think one of the things we just need to be thoughtful about when we ask for patient voices is that it is tied to action in some meaningful way. I think just like asking and then not taking input forward and connected to something meaningful is potentially like problematic and tokenistic. So I think I like how you had that connected to what happens with that next and where's the action that we use that patient voice for. Yeah.
Okay.
Say that it has 2 purposes. One is really a community conversation so that people feel heard, as well as potentially a product that emanates from it.
That's great. So actually, we have one other person first, and then you, and I won't lose you this time, I promise. Yeah.
All right, Michael again. I started life as a health researcher about 25 years ago when I switched from economics, and I didn't know anything, so I started to read, and one of the things that struck me in the literature was an absence of information on health outcomes. The Donabedian thing, structure, process, outcomes. So I was at Statistics Canada, and I thought and looked around and said, what do we need to do for outcomes? And discovered that McMaster University had something called the Health Utility Index, which seemed at the time to be the best generic measure of functional health status. And I further observed that there was a dramatic gulf between the dominant statistics. I inherited vital statistics, which code cause of death biomedically, heart disease, cancer. And what we've learned for over a century of death certificate analysis is that cancer and heart disease are the number 1 and 2, reverse the order, causes of death, so the biggest health problems on the planet or in Canada. But once we started using the McMaster Health Index and we looked at things like pain and cognition and mental health problems, it turns out if you use health-adjusted life expectancy instead of mortality by cause, those things rise to the top of the Richter scale. You know, people like to do cause-deleted life expectancy, and you lose a year or so for cancer, and if you go to risk factors, you lose a year or so for smoking. You lose 6 years of health-adjusted life expectancy for pain or for cognition. So I've been making this argument for years. It seems to no avail, but one thing, if you want to put pain on the Richter scale, is change the way we do the statistics.
Okay. Any response? Norma, you look ready.
Well, no, the thing I would say to that is you're entirely right. Manon Chouanière from University of Montreal has been a leader both in Quebec, where she was part of the group that put together the Quebec Pain Registry, which collected data on about 13 or 15,000 patients with chronic pain. But she's now led a process under the auspices of the Chronic Pain Network to establish, first of all, a minimal data set, which we would look to be collected for patients with chronic pain. And then the next step is to roll that out. Partly we'll do that within the network just to test out the process of it, but there are several other of the chronic disease networks looking at registry processes. And one of the things that we would like to try to do is try to meld databases or data collection so that we can minimize the number of times people have to fill out a registry, capture the fact that many patients cross over in their diseases. They're often recalcitrant in their unwillingness to have only a single disease. So that trying to capture that data effectively or add it into things like the long-form census, the Center on the Longitudinal Study for Aging actually has incorporated some pain questions, so we're starting to pick up on it in the elderly, which apparently is everybody older than I am right now. But capturing that data is critical because, as you say, if you're not measuring it and you're not measuring changes, nobody really knows what's happening.
Great. So, Bonnie? Yeah.
I just wanted to add, too, when we think about outcomes, we use outcomes to describe the patient populations. We also look at the effectiveness of treatment as an outcome. But a bucket of outcomes that we often forget about are implementation outcomes. And I think as we move towards both treatments and strategies for moving knowledge, we really need to think about the implementation outcomes. And those are things like looking at the acceptability, the feasibility, the cost, the sustainability. All of those are really important to consider as well, and I think they often get forgotten.
Great. Thank you for waiting so patiently for like an hour and a half.
Colleen Varco, UBC School of Nursing. Thank you to the panelists. And I just wanted to go back to the question of patient voices and ask the question of whose patient voices will be included, because we haven't had a lot of attention to disparities here today. And I think that those populations that are under greatest threat, people living in poverty, Indigenous people, so on, people that have experience the highest levels of trauma and violence, are also the least likely to be included. So I would like to introduce into our conversation the role of trauma, violence, adverse childhood events, and really steer us away from a single linear relationship between a single injury or trauma and chronic pain, and look at the fact that we are dealing with cumulative and often ongoing assaults. So I think we have to look at the complexity of the situation when we're even talking about patient voices and who's included.
Thank you for that. I think that's a really important perspective. Carol? Yeah.
Carol Estabrooks, University of Alberta. I'd like to second that, Colleen, and add to that a plea that we not leave out older Canadians. The people Bonnie referred to who had surgery without analgesia or anesthesia are now in their 70s and 80s, so they're carrying that baggage as well as all the other cumulative things, as well as the multiple chronic diseases they're encountering. And as the population ages, the rates of dementia will increase, and that population has untreated, unrecognized, and unremitting pain at levels that if I showed those levels to a pediatric audience, I'm sure there'd be a Royal Commission. So it's an important voice that I think can be included. We can include people with dementia, and we can include older adults, and so I just advocate for that. Thanks.
It's great.
Can I just add a comment to that? I totally agree, and I think the other thing we often overlook is that chronic pain is actually a family issue. So chronic pain tends to run in families, and that children who have chronic pain, 50% of their parents have chronic pain, and so it's also, our systems work very siloed, but it's not a childhood separate from adulthood, separate from kind of elderly care issue, and it really is a family kind of cross-generational challenge.
Okay, I think that's it. Louise, do you have a final question, or shall I just thank these amazing people? And I'd also just really like to acknowledge the CEHS organizing committee who made it possible for Carly to come, because we thought it was a particularly important thing to have a patient voice in the conversation, recognizing she doesn't represent all patients, but she represents the reminder to include all patients. So thank you very much to the panel. Really appreciate it.